This isn't my question. It was a question that came in on the web
Yes.
before, so I thought that this would be a good time to discuss it. And it kind of relates in a broad way with what we're talking about. The question the person asked via the webcast was, as we looking at the way we take care of women, at least when they're pregnant, that it seems to be backloaded instead of front-loaded. And the question was, how do we deal with this, given that Medicaid and our organizations that help pay for care for women who can't afford it will only pay for 10 visits? How do we really do this? And I guess I don't have the answer to the question, but I would almost think back to what Michael Liu said earlier with issues relating to the Affordable Care Act coming into play. Now's the time to potentially look at that as one venue that covers people who don't have the means to look at either front-loading it or increasing the number, or you can go all the way to Dick Sass's thoughts. Instead of 10, 11-minute sessions, 1 hour, 40 hours of discussion. So somewhere in between is probably the answer.
Well, let me ask you about that, though. My memory of this ongoing argument of the distribution and periodicity of prenatal visits is that there are as many people who think there should be fewer visits in general, distributed differently, as there are people arguing for more. So I mean, I don't know. I'm not up on that current war, but how does this suggestion fit in with that battle of fewer or more, let alone whether they're front-loaded or back-loaded?
I'll give you my thoughts, and Dodema obviously has his. I mean, I take care of high-risk women who have complicated pregnancies. I see them every 2 weeks, but we're doing something every 2 weeks, adjusting their insulin, adjusting their medication. So I think one size doesn't fit all, like everything else in life. Some people probably need less visits, some people need more. And maybe what you do is you see how people are doing during those visits once you front load them. If they're doing very well, maybe you don't have to see them quite as often. And if they're not doing as well, then maybe you do. But I'll defer and see what other people have to say.
Well, actually, I kind of agree with Pat. I think what's more important than the number of visits is that the visits number are actually appropriate. I think from a normal pregnancy, maybe 10 is enough, but for an abnormal pregnancy, more than 10 may be required depending on what the complication is. However, for this purpose, which we were talking about, pregnancy weight management in pregnancy, appears that the data that we've gotten, including data from other sources as well, suggests that we need more visits early in pregnancy. And so one of the things that I'm going to work with from this conference is the importance of early gestational care, early pregnancy care. And the question I think that I want to ask this community and as well as other communities that are involved is, how do we do that education? Because I think before we can do something, everybody needs to be educated. The obstetricians, the midwives, the family practitioners, and other people that take care of pregnancy needs to realize the impact of the importance of the first few weeks of pregnancy in determining the course of pregnancy, especially when as it concerns the weight gain as well. In addition, the women themselves need to know it. So I think that that's something that we all need to wrestle with, because if the women do not know it's important, if the physicians that take care of them do not know it's important, if the reimbursement companies do not think it's important and they do not want to cover it, then we really can't do much.
Regina, I'm just thinking that this sort of basic issue of public understanding of how important this topic is makes me think of APHA in a sense, because it's population-based. Do we understand this, not just providers, but women in general? What do you think? And is there anything that APHA and all of us could do more to just increase the basic level of interest and knowledge in this area?
Well, I'd like to just offer a suggestion in terms of the previous question. Yeah. Perhaps it's not only focusing on the number of prenatal care visits, but also trying to expand coverage for nutrition counseling. That might be another way to try to address gestational weight gain. In terms of, we in the public health bill, we face a challenge in terms of just helping people understand the importance of public health. You hear the term public health, when it's working, it's invisible. So I think, we have so many issues that are so important, but, this is, kind of biased. My background's maternal and child health, so I would say that this is a very important issue, and we should continue to try to not rest on the guidelines were released in 2009, and but continue to try to be very proactive and aggressive about letting people know that these guidelines are here, and trying to I think the materials, the web-based materials are going to be great. Anything that helps the public understand the issue, and tools that are, having that on a smartphone and being able to type in the information, I think is going to be great in terms of tracking weight gain. I have a 4-year-old, and with all my background, really tried to watch my weight gain, but I can tell you, I struggle with trying to lose those pounds afterwards. And, I know how important that is in terms of wanting to have another child, returning to my weight gain. So, this issue is important across the board, and we should just continue to try to be proactive about it.
So, Sarah?
Oh, excuse me.
I wanted to add a few comments into this, because I think what we're arguing about are these 10 visits during prenatal care, and the reality is there's a difference between public health prevention and medical care. And so those 10 visits from prenatal care were really dealt with how do you provide the best care for women as they enter pregnancy, but pregnancy, as we already talked about in the last 20 years, we've realized that what a woman comes in with during pregnancy sets the course of the rest of her pregnancy. So basically, what we've seen with these arguments about prenatal care is if you have a healthy woman come in for prenatal care, she's healthy, a public health perspective, she's healthy, she's not going to have the complications that can occur, so therefore she would need less care. Actually, the tailoring that Pat was talking about. But if you literally have a woman who's unhealthy, well, then she's going to develop these complications, and so therefore you're going to need to monitor more, because those complications actually tend to become more problematic towards the end of pregnancy. So I think this is where the paradigm shift really comes into play. We need to move away from a clinical model to a public health model, a public health prevention model. So the more that we can actually promote women to come in healthier as weight, healthier as emotional status, just healthier overall well-being, and think about the policies that are associated to that. Marv said before he left, we haven't necessarily looked at other countries. Well, we know that other countries actually have a wonderful postpartum maternity care leave. Where's that in this conversation? We don't have that in America. And we don't necessarily have sort of that support for women to actually be in the healthiest position they possibly can to ensure the future of our next generation. That's where I think we need to start making those big policies.
My mic is not working. We'll just share.
That work?
Okay, that works a little better. Thank you. You said so many things so well. I wanted to say that we can get bogged down in talking about the number of prenatal visits. I think we do want to raise it to a higher conceptual level where we say what care is needed and when. And then also add to that, delivered by whom? Because if it's too expensive to pay for the clinician, the maternal fetal medicine expert to charge for every visit, you look at who else on your team can do just as good a job and who is trained for a piece better than you are. I can also see a future where we have women doing a lot of self-monitoring. We talked about how monitoring at home on a scale that is a smart scale that connects to the electronic health record at the clinic and is then managed by the care coordinator in your patient-centered maternity care home. And that patient gets a call because, we see that you're starting to gain above guidelines now. We are in an evolution to a different kind of prenatal care where numbers are not going to be the main issue.
Lisa.
So I wanted to build on that, the idea about the medical home, because one of the things that is starting to happen just kind of in primary care in general is moving away from kind of this RVU-based payment system where the physician delivers the care one-on-one and then gets reimbursed for what they do, moving more to this idea of kind of a panel, right? So the physician kind of spearheads a panel of patients, and along with an expert team, like Pat was saying, of other people who have expertise in nutrition, or having the social worker involved, or having the nurse practitioner involved, and all these other people who have expertise in being able to do things so that it frees up the physician's time to deal with the more complicated things. And so one of the ideas in like putting this in the setting of prenatal care is exactly what you're saying. So you take an inventory, so to speak, of the women who come in. So this woman comes in, you kind of define what her risk level is for that pregnancy based on how she presents. And then you come up with a care plan for her, as a team in that first prenatal visit, so that you kind of set out what each of her visits are going to look like, and then who's going to be responsible for assessing those things. Because it doesn't necessarily have to be the maternal fetal medicine at every visit. It may just be, okay, this is the care plan. She looks like she's going to need a nutrition, continuity of nutrition throughout the whole pregnancy. We're going to need to get the social work involved. Maybe we can pull WIC in, and then everyone is kind of involved in that team. And then the payment structure will then have to follow that. And so one of the pilots that we're actually doing in our institution in a primary care setting, not in the maternal setting, is going towards that model where you get paid not based on this kind of RVU individual system, but you get paid for the team taking care of a panel of patients. And so I think one idea to start to move in that direction is, of what we can do as the organizations thinking together, is start to put out models like this into the literature, because that's the only way the payment system is going to follow, right? The only way we can lobby for Medicaid or Medicaid or these other payment structures to kind of buy into why we should pay for something else is going to be to put those models out there and then test them in a scientific way to say that they work. So I think we can start to do that. We can start to pilot test different things back in our own settings, and then put those things forward.
I think that's a really important idea, to be able actually to describe different ways of doing this in a way that makes sense to clinicians and systems and payers. Not in the abstract, but very concrete. Here's how we did it, and here are the metrics we tracked and what happened. I think it's a terrific idea.
And that's what that Dante was saying earlier, that what they've tried to do within their practice, they've kind of started to put some of these different models together. And I think publishing, what you've done and how it worked and what the process of getting people involved was, or lessons learned, I mean, those things are going to be helpful for other people to kind of replicate or see if they can replicate in their where they are.
And I was thinking, I don't know, no offense, I haven't gotten the AJPH for a while. But the American Journal of Public Health used to have a section called Notes from the Field. Do we still have that? That's great. Which is, it doesn't mean you have to have this long 12-year, study, blah, blah. But just what people are doing now, real life, in practice. And I think this area would be a fantastic one to highlight, of what people are, different ways of organizing care, with a highlight on this. Raphael.
So I think that all of these ideas are absolutely needed for the radical changes that need to take place for the implementation of the guidelines. At the same time, it's very important to recognize the complexity of the coordinating system that would need to be in place to make all of this work. And this reminds me that in the areas where we have been able to claim some degree of success, there has been, at the end of the day, a champion at the very top that supports the agenda. So Surgeon General Everett Koop and his anti-smoking Surgeon General report had an enormous impact. More recently, Surgeon General Benjamin and her call to action for supporting breastfeeding has already had an impact, even though it was only released in 2010. So I think it's also important at the end of the day that we generate, or the stakeholders who want to move this area forward, to generate the recommendations and know-how that someone of the stature of a Surgeon General could use to issue a call to action because I think that it is what is going to be required at the end of the day to be able to implement these changes.
Do you have a champion in mind? Anybody we can approach?
Well, the Surgeon General is very supportive of breastfeeding. You know, that brings us closer to the topics than others. But, you know, obviously, the First Lady, you know, the impact that she has had with the Let's Move campaign, you know. And the Let's Move campaign, by the way, it was almost an afterthought, but gestational weight gain is there. Breastfeeding is there as well as part of their strategies. So, but for us to be able to convince them, they need to really trust that we know what we're talking about, and that if the recommendations that they issue are followed, that this is going to work. And that's where with gestational weight gain and weight control during pregnancy, it's so important to disseminate and publish the research, the know-how as to when certain conditions happen, yes, it can work, or at what stage, how early should women be approach for these guidelines to actually be implemented in a way that you can show positive results.
Well, I think the point about leadership is absolutely right, and it's essential in a complex society where there's so much going on. There has to be a clear voice that says this is important, we can make progress, and so forth. I mean, just for, it's not quite on point, but sort of a complementary example is that, you know, the rates of teen pregnancy and childbearing have gone down between 40 and 50% over the last 15, 20 years, sort of depending on which measure you're looking at. One of the things that a number of us feel has accelerated the decline in the last several years has been the MTV franchise of 16 and Pregnant and Teen Mom. And there's a bit of research on how adolescent girls respond to that program and what they think and what they do. And it makes me wonder what sort of the popular media face of this issue is that could be constructive. I don't know the answer to that, but I think it's another way of communicating with huge numbers of people relatively efficiently on complicated, somewhat personal, controversial, you know, sort of loaded topics. I don't think any of us here know exactly what that might be, but it's an important part of raising visibility and raising understanding.
Actually, just following on the same thought, because I think it's very clear to all of us that this is a very complex issue, weight gain and nutrition. And you just mentioned about the media, so I was wondering, are there any thoughts of maybe partnering with the food companies or the grocery chains? Because ultimately, it still comes down to the food that's in the store and the food that we can buy. And we know there are very many issues about the kind of food that's available to people, especially when they have limited resources. So my question is, how can we partner with the food industry, with the grocery chains, about making sure that the message that we're giving to our women is also the message that they will get when they get into the stores and into the food and the food places?
Is there anybody here who'd like to comment on that? Kathy.
I know from experience I don't have the world's biggest voice. I was just telling our last speaker about a woman who has started a business that relates nutrition to wellness in a very integrated way. Her name is Zoe Finch-Totten. That's 3 different words. And her business is called The Full Yield. And the website is, surprise, surprise, thefullyield.com. She's a midwife by training, perhaps not coincidentally. And her idea is that we cannot have healthy women and healthy families unless the society gets its act together to do this. And she feels that there are 3 really important partners: the insurance companies, the employers, and the grocery stores. And she has put together in Massachusetts a demonstration project at this point for the business, in which she has engaged insurers to pay for the service that her business is offering, employers to encourage their employees to take advantage of this service, and the service is a full set of both a physical exam with the stated blood work, the usual blood work, so you could understand what the person's problem is. or problems are a wellness plan for that person that then is reimbursed by the insurance company, supported by the employers. And part of that wellness plan is likely to be dietary change, and that dietary change is supported by a line of truly delicious products that are available from one of the grocery stores that's partnering with her, that is partnering both to make these products and put them on the shelves. And those products are at low cost or free during some portion of the wellness prescription, if you will, and after that they're available for people to buy if that's what would be helpful for them. In other words, it's like a completely integrated business, kind of like what Dr. Sass was describing for his integrated plan for the state of Oregon. I think the two of them should talk to one another. I think this is really interesting from the perspective of somebody who teaches public health nutrition, because it's one of the few entrepreneurial opportunities that I've seen really completely developed. So let us wish her all good success.
Linda.
Sarah, I really like your challenge at the beginning, asking us to think about how we get this issue at the top of the issue attention cycle when there's so many competing other issues. I'm wondering if, like Regina with the American Public Health Association, if there's your association and others in this room, perhaps Andrea works at the CDC and others, could get a Surgeon General's warning on home pregnancy test boxes that would appear like on, obviously, tobacco or cigarette boxes that says something to the effect, gaining too little or too much weight puts your baby at risk. Surgeon General says, something that says delaying prenatal care puts your baby at risk. Because we have that same issue. We know that girls who have a negative pregnancy test, which they're likely to do now without ever going to a clinic, are much more likely to get pregnant within the next 6 months and have a positive pregnancy test. So it's really hard to know how to reach an audience that we used to be able to reach when they'd come in for that pregnancy test. If it was negative, we'd start counseling. If it was positive, we'd start counseling. But so I think it's the same kind of dilemma again. How do we reach a group that no longer needs that first visit? That was the hook. And I think you also said, Pat, that when we were talking over here, that offering the ultrasound is the way to get them in the door. So just that whole idea of why shouldn't we have Surgeon General warnings? We know enough about the outcomes, the recommendations are there, and then we have a website that says go here to learn what you should gain during pregnancy. So just I don't know what's possible to mobilize, but it seems like the APHA would be a place to start.
I don't, we all know it was a challenge to actually get the warning on the cigarette packages, and that was a long process. But I mean, that's what you're suggesting is along what I was saying, non-traditional means of educating women about this issue. So maybe it's, maybe there's something we can do in the interim, such as partnering with pharmacists to, when they're providing these prenatal vitamins, or partnering with grocers so that there's material that they can tear off when they pick up their pregnancy test. So, I don't know the history of how the warnings actually finally made it onto the cigarette packaging. I'm sure APHA was involved in that in some way. Yes. You fortunately don't have those types of challenges. But one thing I just wanted to comment about what Sarah talked about, 16 and pregnant, and how that had an effect on the decline of teen pregnancy. But one of the things that I think is a challenge in terms of gestational weight gain is what the popular media glamorizes is the pregnancy bump. So you see these celebrities with these very tiny bellies. They have maintained their weight aside from this small little bump. Fortunately, the data doesn't really show that women are undergaining, but when you're trying to encourage women to gain the appropriate amount of weight, and they're seeing these women gaining about 4 and 5 pounds. I actually know someone that gained 2 pounds. She went into preterm labor and had a lot of other complications, but it happens. There's women that are very concerned about gaining any sort of extra weight.
Yep. Pat, you look loaded.
Oh, you could have a reality show. You couldn't call it The Biggest Loser, but you could call it The Best Gainer. And you could have scenes where she's talking to her family about how much she wants to gain, and she's talking to her provider, and getting really good information about what she should be, how she should be changing her diet away from sugar-sweetened beverages to drinking water, and how easy or how hard it was.
We're sending you to LA.
All right, I'm from Minnesota. It would be a welcome relief.
You know, there are a number of ways to think about using entertainment media and reality shows to help here. It's not something that the Institute of Medicine sort of gravitates to in its sort of normal state. But in fact, I mean, if someone like Dr. Oz or Dr. what's his name talks about these things, they have a huge effect, and that's very well documented. And I think the science here is strong enough that it might be worth a run. Drew Pinsky, you know, he talks about pregnancy all the time, just for example.
I think another one, just briefly, is the Food Network. I had this image that they would, you know, they have these gourmet things, but a reality, you know, chopping block or whatever it is that they do, but something geared towards pregnancy and nutrition, or just general nutrition on low income.
I think it's a very good idea. You know, I don't remember the name of the investigator at CDC, but the group that put together the analysis of what led to decline in highway fatalities. I think his name was Dr. Rosenberg at CDC. But in essence, the conclusion was that it was about 7 things simultaneously, which is really what we're talking about here, everything from professional education to the world's biggest loser, and everything in between. I mean, they had this list that was, you know, airbags, driver's ed, seat belts, car redesign, exit ramp redesign, and speed limit, and so forth. And as best as they could tell, all of them contributed to the decline of highway fatalities, and in a synergistic way. The sum was greater than the whole. The whole was greater than the sum of the parts. And I think that's likely for most of the things we deal with in public health. I mean, once in a while there's a vaccination that's done, or theoretically done, but I think this is going to require a lot of different pieces. I'm loving the uniform, just loving it.
Thank you.
Yeah.
Yeah, I guess I had a couple different comments. One was just about the nutrition information. One of the things that we've talked about is, you know, there's all kinds of apps where you can just scan the UPC code and it gives information. And I think one idea that we've kind of thrown around is, you know, working with March of Dimes or something to have like a logo on foods that would be good for women during pregnancy, or having, you know, you could scan the UPC code and get information on just the nutritional content, folic acid, iron, and it can, there's already apps out there that give you, not related to pregnancy, but give you, you know, alternative choices that would be a healthier choice.
And
or
they're
things
apparently effective. I think the research has suggested that apps actually can make a difference.
Right, so I think there's a lot of tools out there, or tools that we can build just to help inform women, or, you know, educate women, or to empower them to sort of make better food choices. But in general, I think overall, as a society, we've done a terrible job at just teaching people how to cook and how to eat and how to prepare foods and stuff. And so it seems like kind of getting at the issue of what do we do during pregnancy, I don't see how we can get away from, at least initially, referring women to dietitians or helping them get on some, you know, lifestyle modification plan. And we don't really do that except for women with GDM. And we know that women that have GDM tend to gain less weight. And now they're monitoring, you know, themselves and stuff. But we know that works. And I don't think we really have enough data to look at, you know, does just referring them to a dietitian, having, you know, some you know, set number of visits, does that work or not work for women without GDM? And so I think that's one thing, is we just need to kind of build that evidence base there. And then the other thing I just want to point out is that if in the big picture, we actually don't have good data for surveillance, are we meeting the guidelines? We presented the PRAMS data, which is just among 28 states. And so right now, you know, we don't have data from all states to really be able to really look and see, are women achieving the guidelines when we make these big policy interventions and things like that. So that's another area that we really need to focus on.
It's a very important point.
Another idea.
Hi.
Yes, I was just thinking of another access point possibly would be talking to mothers of young women at their own, like, well women visits, for example. I know personally I found that very effective in creating awareness and answering questions about HPV vaccines for their young sons and daughters. Mothers, of course, are very concerned about the health of their family.
So the internist or the OBGYN doing a or just a visit with a woman who has a 10-year-old or a 12-year-old or whatever, the conversations with the mother on behalf of the young.
Exactly. We'll just say, like, what are you doing nutritionally in your family? Are you aware of how much that can impact your daughter's reproductive health in the future? And maybe having a tear sheet or a card that could be provided to mothers who are interested in saying, oh, that's very interesting, and that would have, you know, links to internet sites or educational programs, so they realize, because we're talking about patients being self-motivated in their own care and how that requires a support system. Well, there are families in place for many young women have the benefit of having a supportive family, and mothers who are willing to do what they can to help educate their child. Why not get the moms excited about that, give them access to the tools to do that for their own family while they're still technically in pediatric care, but in that lapse before they go in for their first pregnancy test or they go in for their IUD at 18.
Very helpful, thank you.
So I had another thought of trying to reach the general public is, you know, they do revise science textbooks. And in human biology, I think I'm sure they actually are covering fetal programming, but are they covering the fact that maternal nutritional status actually affects the health of the child in the course of pregnancy? We should be making sure that examples are being used in science books that are going to cover all high school students so that that information is actually out there. I think it's just another mechanism of trying to educate the general public on the importance of nutrition and how nutrition influences your overall health life.
Hi, I'm Linda Myers, IOM. It occurs to me, your mention of entertainment industry, that there's another resource that we haven't taken advantage enough of, which is the HBO IOM documentary film series called The Weight of the Nation, which has segments in it of pregnancy counseling and trying to, you know, have a healthy weight, and those are downloadable free. There's nice discussion guides, and we could probably make better use of that information. Elsie Taveras is one of the people who's featured in it, so that would be something to think about.
What sort of audience are those attracting? What sort of numbers? Do you have any idea?
No, I mean, we do have some. You know, how many eyeballs were on it, but I couldn't begin to remember. But we do have that.
Do you know about that, Kathy and Ann? No, that's news. Okay.
No,
Ann knows.
Yeah, we don't know. She doesn't know the numbers, but yeah.
Oh, but you know about this opportunity. Okay. Anything else, or is it time to turn it over to Kathy? Is it? Well, Pat and Regina, may I thank you both for joining me up here. That was fun. Thanks very much.